Welcome back to the Deep Dive. Today we're tackling something, well, pretty common and definitely disorienting if you've had it. We're looking at a set of revision notes you shared with us, specifically focusing on benign paroxysmal positional vertigo, BPPV.
That's right. We've got your notes here, and the plan is to sort of unpack them together, pull out the really key high-yield stuff about BPPV for you.
Exactly. Think of this as us helping you zero in on the essentials from your study material. BPPV. It's that sudden room-spinning feeling, right? Can be quite confusing.
Absolutely. So we'll go through the notes section by section, just like you would for revision. Definition, causes, risks, how it works.
Diagnosis, treatment, the whole lot, drawn straight from the material you've got.
Let's do it.
Perfect. So let's start right there with the definition. What exactly is BPPV according to these notes?
Okay, so fundamentally it's described as a common inner ear disorder.
Common, okay.
And its main feature is these brief episodes of vertigo, that spinning sensation or intense dizziness.
Right, but it's not there all the time.
The
note's it's triggered, yeah.
Exactly. That's the positional part. It's specifically brought on by head movements. And the notes explain the underlying cause involves these loose calcified particles, otoliths or otoconia.
Tiny crystals, basically, floating around where they shouldn't be in the semicircular canals of the inner ear.
Precisely. Those canals are crucial for balance. Your notes also mention some potential triggers for getting these crystals loose in the first place.
Like what?
Things like a head injury are mentioned, maybe some viral infections impacting the inner ear, even conditions like Meniere's disease, though that's maybe less common than, well, than no clear reason at all.
The idiopathic cause.
Yeah,
happens.
Often it's idiopathic. And the notes mention a typical onset age, around 55.
Yeah, seems less common when you're younger. It becomes more likely as people get older. Okay, so common inner ear thing. Brief spinning triggered by head moves, caused by loose crystals, often no specific trigger, more common later in life. Leads us nicely to the next bit, the etiology, the why.
Right, the cause. The notes really drill down here. It's all about the displacement of those calcium carbonate crystals, the otoconia.
From where they're supposed to be. The utricle, is it?
Yes, from the utricle into those semicircular canals we mentioned.
And that's the problem, them being in the canals.
That's the problem, because their movement in there abnormally stimulates the vestibular system, your balance organ. That's the key mechanism.
And while it's often idiopathic, those other things can play a part.
Yes, the notes reiterate head injury, inner ear infections, maybe just age-related degenerative changes in the ear, or it can just occur spontaneously.
Okay, so who's more likely to get this? Your notes cover risk factors.
Yep, several factors listed here. Older age is a big one. The notes mention a peak incidence between 40 and 60 years.
And there's that gender difference, too, which seems quite significant.
Very notable. It's more prevalent in women. The notes suggest a ratio of about 1 male to 2 females.
So twice as common in women. Interesting. What else?
Having Meniere's disease is listed. There's apparently quite a high co-diagnosis rate, maybe up to 30%, according to these notes.
Wow.
Also, associations with anxiety and migraine, especially noted in children who get BPPV.
Right. And the things we already mentioned, like head injury or having had BPPV before.
Yes, prior BPPV episodes and a family history are also listed as increasing the risk.
So main risk factors seem to be age, being female, and perhaps having other related ear or neurological type conditions.
That sums up the risk factors in these notes pretty well.
All right, let's get into the really interesting bit, the mechanics, the pathophysiology. How do these little crystals actually make the room spin? Walk us through the steps from the notes.
Okay, so step 1 is what we've been talking about, otoconia displacement. The crystals detach and float into the semicircular canals.
Right, and those canals are filled with fluid, the endolymph, so the crystals are like grit in the system.
That's a good way to think about it. Step 2 is fluid flow disruption. When you move your head, these loose crystals move too, and they drag the endolymph fluid along with them, or just disrupt its normal flow.
And normally that fluid movement is what tells your brain about head position. So if the crystals are messing with the flow,
the signal going to the brain is wrong. That's step 3. Abnormal brain signals. The disturbed fluid movement sends incorrect, often exaggerated, signals about rotation or movement.
Even from a small head movement.
Exactly. The brain gets this faulty information suggesting you're moving much more or differently than you actually are.
Which leads directly to the symptom.
Step 4, vertigo symptoms. That intense, brief spinning is the brain's reaction to those confusing, incorrect signals from the inner ear, all because of those displaced crystals.
It's amazing, really. Such a tiny physical change causing such a dramatic feeling. Now, okay, BPPV is common, but if someone's getting vertigo, it's not always BPPV. Your notes have a really important section on differential diagnosis. What else could it be?
Yeah, this is crucial. The notes list other potential culprits for vertigo or dizziness. Things like acute vestibular labyrinthitis or Meniere's disease, again, other inner ear issues.
Okay.
And even some medications can cause dizziness, that's mentioned too.
But the really key thing here seems to be the red flags. Symptoms that mean you need to think beyond BPPV?
Absolutely vital, according to these notes.
How?
Red flags include things like hearing loss just in one ear, unilateral hearing loss,
Okay.
tinnitus ringing in the ears, a new or severe headache, any focal neurological signs, and what the notes call atypical nystagmus.
Focal neurological signs.
No.
You mean like sudden weakness, numbness, vision changes, the trouble speaking?
Yes.
Stuff that suggests a brain issue.
Precisely. And atypical nystagmus means that involuntary eye movements seen don't fit the specific pattern typical of BPPV during testing.
And why are these red flags? What serious things could they point to?
Well, the notes explain they could indicate more serious underlying neurological conditions, like multiple sclerosis, or a TIA, a mini stroke, or a full stroke.
Okay, serious stuff.
Yeah. Or potentially brainstem lesions, or even tumors like an acoustic neuroma affecting the hearing and balance nerve.
Right.
They could also point to other specific ear problems like herpes zoster oticus shingles affecting the ear, or conditions affecting the middle ear bones like otosclerosis or cholesteatoma, even vascular problems like reduced blood flow to the back of the brain, vertebrobasilar insufficiency.
So a whole range of possibilities.
Definitely. And the notes are very clear. If you see any of these red flags, it warrants urgent investigation and likely a specialist referral to rule these other things out.
That's such a critical point. BPPV is common, but don't miss the red flags. Okay, so speaking of common, let's look at the epidemiology. Your notes give some UK figures. How widespread is this?
The notes suggest a prevalence of around 2–3% in the general population. So yeah, it confirms it's definitely a common condition.
And the numbers back up what we saw in the risk factors too, right? About age and gender.
They do. Peak incidence noted here between 50 and 70 years old, so refining that age bracket slightly. And again, women affected about twice as often as men.
So summing up the epidemiology, pretty common. It gets more common as you get older and hits women more often.
That's the picture the notes paint.
Okay, let's move to the clinical features. What does it actually look and feel like for the person experiencing it? What's the classic presentation, according to your notes?
Classic presentation is those short bursts of vertigo, typically lasting less than a minute,
Okay.
and crucially triggered by changes in head position, looking up, lying down, rolling over in bed, those kinds of movements.
Does it cause other symptoms besides the spinning?
Yes, nausea and sometimes vomiting are common during an episode, and afterwards people might feel a bit unsteady, some postural imbalance.
And the notes seem to really emphasize some key diagnostic features here.
Yes, it boils down to vertigo after specific head movements, episodes lasting seconds to maybe a minute, and importantly, NO-associated neurological deficits. That links back to the red flags.
Right, no weakness, numbness, vision changes, etc.
Exactly. Other points mentioned. The spinning stops quickly if you keep your head still. It's often worse in the mornings. And typically, there are no hearing issues or tinnitus, which again helps differentiate it.
Okay.
Though people might feel a bit lightheaded or generally off balance between the main attacks. And this imbalance, especially in older folk, can unfortunately lead to falls.
So summarizing the features.
Mm-hmm.
Episodic, positional vertigo, possible nausea, no neurological signs, quick resolution when still. That distinct pattern sounds key for diagnosis, which leads us to investigations. How is BPPV actually diagnosed?
Well, this is a really high yield point from your notes. The diagnosis is primarily clinical. It hinges on the patient's story, the history, and the physical examination.
And a big takeaway here seems to be no imaging or laboratory tests required for typical BPPV.
That's right. For a classic presentation, you usually don't need scans or blood tests.
So how do you confirm it clinically?
While the notes say other tests can be used if things are unclear, the main diagnostic tool is a specific physical test.
The Dix-Hallpike maneuver, probably the most well-known test associated with BPPV.
Yeah.
How do the notes describe doing it?
Okay, so the patient starts sitting up. You turn their head 45 degrees to one side.
Right.
Then you quickly help them lie flat on their back, often with their head hanging slightly off the end of the examination couch, still turned to the side.
And then you watch and wait.
Exactly. You observe their eyes closely and ask them if they feel the vertigo, typically for about 30 seconds.
What makes it a positive test? What are you looking for?
A positive test, according to the notes, is when you reproduce the patient's vertigo symptoms and you see a specific type of involuntary eye movement, that nystagmus we mentioned.
And it's a particular type of nystagmus for BPPV.
Yes, typically torsional, meaning a sort of twisting movement of the eyes. It often has a short delay before it starts latency, and then it tends to fade if you hold the position fatigability.
Okay. And the notes mention being careful with some patients.
Yes, precautions are needed for people with neck problems or certain heart or vascular conditions. You need to be gentle.
Makes sense. And the notes do clarify when you would need imaging, like an MRI.
Yes, if the diagnosis isn't certain after the maneuver, if any of those neurological red flags are present, or if the symptoms just aren't getting better with the standard treatment,
Right.
or if you suspect something else might have caused the BPPV secondarily, like an infection or injury. But for straightforward cases, the Dix-Hallpike is usually the key to confirm it and avoid unnecessary tests.
So, good history exam, Dix-Hallpike, usually enough. Okay, so once it's diagnosed, how do you manage it? What about treatment in the notes?
The absolute mainstay of treatment, highlighted clearly in the notes, are the canalith repositioning maneuvers.
Right, these are physical movements to get those crystals back where they belong. Which ones are mentioned?
The main one discussed is the Epley maneuver. It's a specific sequence of head movements designed to guide the otoconia out of the posterior canal, the most common place for them to be, and back into the utricle where they don't cause trouble.
Okay, the Epley. Any others?
Brandt-Daroff exercises are also mentioned. These are different exercises patients can learn to do themselves at home. The idea is they might help disperse the crystal debris or maybe help the brain adapt over time.
What about medications? Do they play a big role?
The notes are quite specific here. Medications are mainly for symptom relief only. Things like antihistamines, maybe beta-histine or anticholinergics, can sometimes help reduce the nausea or the intensity of the spinning short term.
But they don't fix the underlying crystal problem.
Exactly. They don't reposition the crystals, so their long-term effectiveness for BPPV itself is limited. The maneuvers are the core treatment.
Okay, maneuvers first. What about vestibular rehabilitation? Is that mentioned?
Yes, it's noted as potentially helpful, especially if someone has lingering dizziness or imbalance even after the main vertigo attacks are gone. It's basically exercises to help the brain compensate.
And what about just waiting? Does it ever go away on its own? The notes cover other considerations.
It can, yes. Spontaneous resolution is definitely possible, often happening over weeks or months, but the maneuvers usually provide much quicker relief.
Makes sense.
Lifestyle advice is also mentioned, like trying to avoid the specific head movements that trigger it, being careful when getting up, maybe adjusting sleeping position.
And safety stuff like being cautious about driving or work activities until it's under control.
Yes, definitely. Specialist referral is usually kept for tricky cases, diagnostic uncertainty, red flags present, or if standard maneuvers aren't working after several tries.
And surgery.
Mentioned as a very rare last resort for really severe persistent symptoms that don't respond to anything else. Procedures like plugging the canal are listed, but the notes warn they carry significant risks like hearing loss.
So the pathway is clear. Maneuvers are key, meds for symptoms if needed, maybe rehab, it might resolve anyway, but maneuvers are faster. Specialists in surgery are way down the line for most people. Given that, what's the outlook?
The prognosis. Generally pretty good. The notes state it's usually self-limiting and responds well to the repositioning maneuvers.
But it can come back, right?
Yes, recurrence is definitely a thing. The notes mention recurrence rates around 50% within 5 years. So while you can treat an episode effectively, there's a decent chance it might happen again down the road.
But presumably, the maneuvers work again if it does recur.
Usually, yes. So the overall long-term outlook is favorable for getting it resolved each time. Treatment brings rapid relief for most.
Okay, last section in the notes. Complications. What are the potential downsides?
The main things listed are the impact on quality of life. These recurrent episodes can really limit what people feel able to do.
Yeah, I can imagine the unpredictability must be difficult.
Absolutely. Anxiety and particularly a fear of falling are highlighted as significant issues, especially for older people.
And can falls actually happen?
Yes, the notes mention that in rare cases, a severe vertigo attack could lead to an injury from a fall.
So, while the condition itself is benign, meaning not life-threatening neurologically, its effects on daily life, anxiety, and fall risk are definitely not trivial.
Exactly. It might not be dangerous in itself, but its consequences can be significant for the individual.
Okay, I think that covers the main points pulled from your revision notes there.
Okay.
Definition right through to complications.
Yeah, we've walked through the definition, the cause, the risks, the mechanism, how it differs from other things, especially those red flags, how common it is, the classic symptoms, the Dix-Hallpike diagnosis, the Epley maneuver treatment, prognosis, and potential issues.
We really have. Hopefully, breaking it down like this, focusing on the key points from your notes, makes it all a bit clearer and more memorable for your revision. The core message seems to be BPPV is common, positional vertigo, cause loose crystals, diagnosis clinical plus Dix-Hallpike, treatment repositioning maneuvers, usually very effective.
That's a great summary. And it really is fascinating, isn't it? How our whole sense of balance hangs on these tiny structures, fluid dynamics, little crystals. The complexity of the inner ear is just incredible. Makes you think about what's involved just in keeping us upright without us even noticing.
It really does. A brilliant thought to end on. So, just before we wrap up, for more information and resources based on today's topic and related areas, you can check out PassThemSRA.com and FreeMSRA.com.
Thank you for joining us for this deep dive into your BPPV notes.
Until next time.